Welcome everyone to another excellent journal club. Today we have with us a very wonderful guest, Dr. Jeff Walter, and I'll let him introduce himself further.
Sure. Glad to be here. I'm a vestibular physical therapist. I work at Geisinger Medical Center in central Pennsylvania. I help head our balance center. I work with several otologists, audiologists, and other physical therapists at our center. I only see patients with balance disorders or dizziness. I have a side interest also in education and teaching. I'm an adjunct faculty at Misericordia in the University of Scranton, and I teach continuing education courses also.
Yes, indeed. And you do research, so just everything basically.
Yeah, research interest is in superior canal dehiscence, BPPV, and vestibular schwannomas.
Awesome. So speaking of those interesting topics, we're going to get right into our topic tonight, which is entitled Clinical Pearls from an Unusual Case of Vertigo. And we did post up the article so folks can look at that as well. And when I start these journal clubs, by now, anyone who's watched a few knows that I like to just kind of get everybody on the same page really quickly. So we're going to talk just briefly about what is the vestibular system. It's our inner ear balance system. It lives near our hearing structures. I like to say they're neighbors. The vestibular apparatus, or the sensor that we have in our inner ear, has to send information along vestibular nerve up to the brainstem, and that information goes along to different parts of the brain so that information about where we are gets integrated with information from other sensors such as our eyes and the sensors in our joints, which tell us whether our body is in a certain position. We call this proprioception. Each joint has sensors, so we get a lot of information that gets integrated at the brain level, but we really need the inner ear on the right and the left, these vestibular sensors on both sides, we have one on each side, to ideally be in agreement, I like to say. So, that's what the brain likes. The brain likes when all this information is in a kind of cohesive set of sensations that kind of agree. So when that doesn't happen because there's something wrong with the vestibular sensor on one side, we can get a variety of symptoms, and we'll talk more about that shortly. So, keeping that in mind, we'll talk about one particular pathology here that's mentioned early in the article that we're covering, and that is the vestibular schwannoma. And I'm going to let Jeff talk for a bit and just define that for us.
Sure. So these are typically benign growths. So that's one thing to reinforce with your patient is these are rarely cancerous. They can vary highly in size. More than 95% of the time they're unilateral. When they're bilateral, your patient probably has what's called neurofibromatosis type 2. So if they're occurring bilaterally, that's likely what the patient has. Interestingly, they can grow very slowly, they can grow rapidly, and we've learned that about 50% of them grow for a while and then just stop. So just because you have a schwannoma doesn't mean it's going to grow indefinitely. So that's why it's become kind of popular to kind of monitor these first before you do anything about them, because if they're small and they stall in their growth, you're probably just better off living with it in your head if it's not going to expand. It's more concerning the closer it is to your brainstem. So they could be closer to the brainstem along the course of the nerve, or they could be closer to the labyrinthine organ. They emanate from, these used to be called, and they still are called, acoustic neuromas, which is really a misnomer because you would think, I have a tumor and it must be on my hearing nerve. Mm-hmm. And they're not. They emanate from the vestibular nerve, not the cochlear nerve, although given the close proximity of those nerves to each other, you can certainly have cochlear nerve involvement. But these tumors actually emanate from the vestibular nerve, and they form from Schwann cells, which produce myelin in our central nervous system on the surface of the nerve. So that's where they emanate from.
Great. And you said if they stay small, we can monitor them. Can you give do you have a sense of scope on what that means size-wise? What are we talking, millimeters, I believe?
Yeah, they're usually, a lot of them are sub-centimeter. And as far as whether we watch it or not, a big factor is the patient's age. So if you're younger and it's growing, you're much more likely to have these removed. If you're older and it's growing minimally or very slowly, you're much less likely to have it observed or pursue gamma knife, which is focalized radiation to the tumor site. But they vary highly in size. I mean, they could be the size of a small piece of fruit or a little bit bigger than the end of your pen. So they really vary highly in size.
Fair enough. All right, that's great information. So, according to the article, which I imagine is drawn from very accurate sources, it is estimated that lifetime prevalence is about 1 in 1,000 for the population, and it accounts for approximately 85% of what they call cerebellopontine angle tumors. So, that kind of area, kind of in the kind of inner ear leading up to the brainstem, which is the pons is part of the brainstem, and then up kind of towards the cerebellum, which is kind of a larger brain area, but still at the base of our brain, if you will. So that kind of region, kind of has the angle has to do with how they see it on imaging, I believe. And so there are other possibilities that are competitors if one were to see a tumor on imaging, ranging from meningioma to kind of other sort of issues in that same region. But luckily, as you mentioned, many stay benign, but where it would not be cancer but still could cause a problem is the size, right? So if the size gets large enough, it starts to kind of push on other structures in the area, which could impede function and create issues around the cranial nerves, the cerebellum, that brainstem, that whole area. If that tumor were to get large enough, now we're going to have impaired function of those structures, and then we're definitely going to see signs of that, and that's not something we want because the brainstem and the cerebellum have very important critical functions to things ranging from our breathing and heart rate and things like that, all the way to our walking, our balance, our ability to coordinate movement. So this is where they might want to intervene. Is that correct, Dr. Walter?
Correct. It can also cause an obstructive hydrocephalus too if they get large. And the larger they get, the more difficult they are to extract. So that's the other issue you run into as they become larger. And when they're bilateral, then you have a dilemma because when these are removed, you will almost always lose typically all vestibular function in an ear. Sometimes some is spared. Frequently, you lose the hearing in the involved ear also. So you run into a situation where a patient has it bilaterally, but they could go, if you remove both of them, they could end up deaf and with bilateral complete vestibular loss. But sometimes you have to do that to save the patient's life if they're growing at a great rate. So that's what the patient has to be counseled on, because I had a patient just the other day that said, well, why don't we just remove it? And then would my ringing get better and my hearing get better? And I said, probably not. It would probably get worse. So patients have to understand that before they weigh the pros and cons of surgery, for sure.
Right. And this is where, we have these conditions and, it's the dream would be for them not to exist, right? We wouldn't have these problems. So when we're dealing with this and we're talking with patients, even as physical therapists, although we're certainly not advising surgery, no surgery, folks still bring us questions sometimes. So it's good to be informed. It's good to be aware. And we certainly lean heavily on the physicians who would, be monitoring that size and kind of try to make that decision in collaboration with the patient to say, this is what I advise and here's why, and making those informed decisions. So
one little teaching point,
I think go ahead.
Sure, that's important for therapists is, interestingly, the more vestibular function you have on the disease side, on the side that you have the tumor, the more function that's there before surgery, the more likely you are after surgery to be severely vertiginous and have substantial balance deficits. What we do preoperative vestibular testing on all patients with vestibular schwannomas, and when patients don't have any caloric function in the ear, and they have multiple pieces of evidence that there's no vestibular function, no hearing in the involved ear, interestingly, post-operatively, they're often not all that vertiginous and may not have substantial additive balance deficit after removal of the tumor. So the more vestibular function that's there before surgery, and that there's a precipitous drop with the removal of the tumor, those are the patients that really struggle after surgery with vertigo and imbalance and oscillopsia. So it's good to know if you're able to obtain it, and if it's been done. It's nice as a therapist to know, well, what was the status of the vestibular system before surgery, and then after surgery, you're probably going to be dealing with an ear that's vestibular dead.
Right. Definitely helpful for expectations management on the part of the clinician and the patient, and then also just knowing that, I mean, those folks, in my experience, can still be rehabbed as far as improving their balance and driving down their dizziness, but know that there's going to probably be more work. And maybe be a little more patient, kind of allow for a longer time frame to try to help those patients come to a new homeostasis,
Right.
which is what
Another teaching point, I think, is we often kind of lump all patients with unilateral vestibular loss together, but I wouldn't, because these patients often lose all vestibular function. All three canals are lose their sensory signal and their otoliths, so they really lose 5 sensory structures from the vestibular organ on one side. A lot of subjects with vestibular neuritis, which is a unilateral disorder, only lose function in their superior vestibular nerves, still have residual saccular and posterior canal function,
Right.
where these patients often have a complete loss of function unilaterally, so they tend to be a bit more impaired. Plus, we know now more and more that hearing is important for balance. So again, your patient with vestibular neuritis still has hearing bilaterally, whereas your patient with the schwannoma may have hearing impairment, very likely has hearing impairment on one side, which affects your spatial orientation too. So in general, these patients tend to be more impaired than your patients with, say, vestibular neuritis.
For sure. No, those are excellent points. Thank you. So keeping those things in mind, it's also good to be aware that as we're kind of maybe the first person to suspect at times a vestibular schwannoma, because not every patient has the same path. So you may be coming into you and they just think, oh, I think I have crystals like my neighbor. We have that. Everyone hopes in a way that they have crystals because they've heard it can be magically fixed in a session or two by Helena or by Dr. Walter, right? So, we're going to kind of keep ear out, not to be punny, for descriptions of hearing loss. Which, according to this article at least, cites about at least half will probably have some signs of that. They may or may not have dizziness, about 17% in this particular article listed, and they may report some ringing in the ears, tinnitus, or they may not. So it's important to note that because generally this kind of growth could be gradual, and so the compression on the structures can be gradual, their brain is constantly, in theory, trying to compensate for that. And, even though there's some kind of mild unilateral loss essentially happening from a vestibular standpoint, the brain will be trying to compensate. So they may have more of a balanced report. And rather than saying, oh, I suddenly get dizzy or I have major vertigo all of a sudden, which we certainly could characterize as more sounding like BPPV or Meniere's or some other something that could also be mistaken, if you will, for vestibular schwannoma. So I did pull from an article here. I mostly agree with this chart. Nothing's ever 100%, I feel. So I just recently had Dr. Sharon on, and he talked about the auditory symptoms that one can present with migraine. But setting that aside, most of the rest of the chart feels pretty on point. Just as a way to try to help folks as they think about what symptoms might present with different conditions and what we might be trying to note in that realm. We're still, once we get suspicious, we're pointing to testing. At least that's my way. So if I'm hearing about hearing loss and they haven't had a hearing test, I wanted that to be happening. If I'm hearing about some sort of like episodic vertigo with hearing loss that sounds like it could be Meniere's or something, I'm going to be ordering, or asking for, should I say, some vestibular testing, formal VNG, calorics, that kind of thing. So anything you want to add to that?
Yeah, so the hearing loss tends to be gradual. It's the exception, but there are cases where it can be sudden. We think it's when a vessel supplying the cochlea with nourishment gets occluded by growth of the tumor. But keep it in mind when a patient's had a gradual hearing loss. And interestingly, in many cases, awareness of sound can be preserved, but specifically with vestibular schwannomas, you have difficulty understanding words. So on an audiogram, which I don't know if we're going to review that later or not,
Yeah.
a specific thing that audiologists will look at is word recognition scores. And as a group, patients with what's called retrocochlear pathology, meaning the pathologies not in the cochlea itself, but in this example along the vestibular nerve, they often have trouble making, comprehending words, speech, even though they have an awareness of sound. I've seen a number of patients with these schwannomas that when you look at their pure tones, which is just your awareness of sound occurring in your environment, tones, beeps, there's hardly any difference between the two sides. But when you go down to the audiogram and you look at their ability to understand words, it's markedly worse on the side that they have the tumor on. And then just one other comment is, been involved in a study where we're looking at in individuals with unilateral hearing loss to look for associated vestibular findings and then also correlated with whether they ended up having a vestibular schwannoma or not. Frequently, even in subjects with unilateral hearing loss that do not complain of dizziness or imbalance, they can often have signs of vestibular hypofunction, but with schwannoma, it evolves so slowly that they compensate as it grows, and they really don't often offer that as a complaint. But when you test their vestibular function, it's often still suppressed on the side where they have the tumor.
Makes sense. All right, so we know that imaging to detect a vestibular schwannoma can be pursued to try to, kind of figure out if someone might be dealing with this. And you mentioned, and this article, did the same, this kind of possible combination of report of hearing loss, tinnitus, and a particular deterioration of the word recognition scores. Now we're going to dig into a little more about this kind of particular case. So this patient we're going to get to shortly had some symptoms with coughing. So let's talk about cough-induced vertigo. When I hear about that, in courses I've been to, most folks would say, oh, that sounds like a third window symptom. And let's have you go ahead and explain why, Dr. Walter.
Sure. So coughing increases intracranial pressure. So if we look at the nice illustration that we have here in our slide, that pressure, if you do not have bone overlying your superior canal, your brain is in contact with your membranous canal, all right, because the bone is eroded. So with supracanal dehiscence, the pressure can be transmitted from your cranium down through your vestibular organ because of that dehiscence. And that would cause utriculopedal displacement of your cupula in your superior or anterior canal. Those are synonyms, which is an inhibitory stimuli. So basically, coughing can create this transient vestibular inhibition from the involved superior canal, making you, obviously feel like you're spinning. So that's the mechanism, is that pathway, the bone is no longer blocking the pressure wave that's occurring within the skull down through the ear. So normally there's a bony division between your membranous semicircular canal and your brain, but with dehiscence it's missing, and those pressure waves can travel through that opening and displace your cupula, creating illusions of movement from patients.
What other symptoms might someone with that sort of dehiscence report?
Okay, so a variety of symptoms. One is echoing of your voice, which is called autophony, autophony. It's pronounced autophony, which is hearing your own voice reverberate in your ear. It's really annoying for patients that have it. They tend to soft talk to mitigate it. Pulsatile tinnitus. So that when you ask about tinnitus with patients, you always want to know if it's high pitched or low pitched. Low pitched more common with Meniere's, high pitched, for example, more common with an aging ear. And we're concerned when tinnitus is unilateral versus bilateral. With age-related hearing loss, it tends to be bilateral. More frequently with disease, it tends to be unilateral. You also want to ask if it's pulsatile. The tinnitus with superior canal dehiscence is typically in sync with your pulse, so it's like a whooshing in the ear. Whoosh, whoosh. So pulsatile tinnitus is another common complaint. We just went over dizziness provoked with pressure, coughing, sneezing, blowing your nose, defecation, those kind of activities, weightlifting. And then and by the way, that's called Henneberg sign, is vestibular symptoms induced by pressure is Henneberg sign. And then what can be really problematic for patients is loud sounds can make them feel like they're going to fall or tilt or spin. And that's called Tullio's phenomena, is vestibular symptoms elicited by sound. So the ear becomes sound sensitive. You can also develop a hypersensitivity to sounds inside your body. We talked about having pulsatile tinnitus, but patients can hear their eyes move and frequently hear crepitus in their joints in their involved ear. They can hear their digestive sounds. And they often complain that when their heels clack on the ground with walking, that it reverberates in their involved ear. So your ear, when you have this dehiscence, the ear has become an amplifier to internal noises, but yet it's less effective at hearing things in your environment.
Right.
So it's odd. You don't hear things in your environment as well in the diseased ear because you have energy escaping out this window, but then you're hearing all these things in your body that you normally wouldn't hear.
Right.
So those are some things to think about. So historically, when you go back before this was discovered, patients were frequently thought to have psychotic disorder because they're telling you, my voice echoes in my ear, I get dizzy when I poop. If it's too loud, I feel like I'm going to fall over, and I can hear my eyeballs move.
For sure.
If you don't understand the mechanics of this, that's,
sounds odd.
For care, they're thinking of referral, not to.
Right, so now we know better, so we'll be able to pay more attention and make sure that at least gets checked before we jump to any other conclusions of that nature. So, coughing, dizziness, there's some other possibilities that are non-vestibular or kind of not inner ear vestibular. So maybe you could discuss those as well here.
Sure. So it's been reported in some instances with Chiari malformation that you can have pressure-induced dizziness. So that's one thing you want to keep in mind. With that in association with it, you'd want to see downbeat nystagmus. And then with some cardiovascular disorders, cough-induced syncope has been mentioned because coughing transiently reduces venous return. So you can think about cardiovascular dizziness, Chiari, superior canal dehiscence are things we think about when we hear about cough-related disease.
For sure. All right, so now we jump right into some of your slides because, why reinvent the wheel? So your patient case, that's so wonderfully described in the article as well, is a 76-year-old male with a 7-month history of vertigo. It's particularly triggered by coughing and lasting about a minute. And then some milder dizziness with bending forward, sitting up from lying down, and just kind of moving their head around, and that would be more lasting seconds. They also reported horizontal oscillopsia, which is kind of what most people would describe as double vision, along with these episodes of vertigo when the coughing provokes it, and did not report anything that was prolonged minutes, hours, which is kind of what we would listen for with migraine or Meniere's, for example. Did I capture that pretty well there?
Yeah, he really didn't have diplopia. So he would get, with coughing, he'd get oscillopsia. He just felt like his visual world would take off,
okay.
Become unstable, but there was no diplopia, just to clarify.
Thank you.
Said.
No, that's
so
helpful.
Generally, when any sort of generalized activity had some imbalance, but coughing was really the specific trigger for strong attacks of vertigo that he would experience.
Excellent.
And
Understood.
it's going on for 7 months.
Right, right.
Practicing us.
All right. And you also reported here no history of falls, no other positional vertigo other than what was previously described on the other slide, and no acute hearing loss, no tinnitus. Some of these other, the autophony, which you mentioned, so kind of trying to listen for what does this sound like? What are these symptoms? I would say the pattern recognition we're looking for, right, Dr. Walter?
Yeah, so he really, we went over the symptoms of superior canal dehiscence, and he's missing most of them except for cough-induced dizziness. So that would seem to make that less likely. So it's important, always ask your patient about cochlear involvement. And with him, there was no associated acute hearing loss with his dizziness, no tinnitus associated with the development of his dizziness. And like we said, ask about fullness, autophony, pain in the ear, otalgia, infection, otorrhea would be discharged from the ear. If you get into vestibular therapy, make sure you get comfortable asking about the health of patients' cochleas. It's important to help you with differential diagnosis.
Right, since they're neighbors. All right. So the patient had seen a physical therapist who did not feel they could have a positive impact with vestibular rehab and was concerned for possible superior semicircular canal dehiscence. So they were going to consider imaging. So I'll let you talk through that.
Yeah, this was an outside therapist, not in our system.
Right.
Saw the patient, and since the principal concern of the patient was, I cough and I spin, he's like, well, I don't think vestibular rehab is going to be real helpful for that, which was a good judgment.
Right.
And had one of the initial thoughts was superior canal dehiscence, which I would agree that would be one of my chief thoughts. Now, imaging for superior canal dehiscence, you want temporal bone CT with very fine cuts. An MRI of the brain can give you an idea that a patient might have dehiscence. But if we're looking for a bony defect, remember we want CT. CT is good for a bone, looking for a bone-related problem or bleeding. Mm-hmm. MRI is optimal for a soft tissue anomaly. So for like an acoustic tumor, MRI is optimal. For superior canal dehiscence, really you want a CT of the temporal bone with very fine cuts, reformatted in the plane of the superior canal. But this patient, unfortunately, the primary care, I believe, initially ordered an MRI because wasn't familiar with exactly what type of imaging needed to be done. And the MRI suggested that it didn't appear the canal was dehiscent, but did mention, well, you might want to get a temporal bone CT if that's really your chief concern. So the interpretation on this MRI, which was of the brain with internal auditory canal focus with contrast, the impression was that it was normal. Now, we didn't actually see this image. This was the report I was handed. So what you're seeing is what I saw when I saw the patient.
So could this MRI, or should this MRI have shown, just out of curiosity, something like a vestibular schwannoma, or would it have to be ordered a specific way to show that sort of pathology?
This MRI was ordered optimally to visualize a vestibular schwannoma. So properties of an MRI you definitely want, when you're thinking about schwannoma, it should have contrast. A lot of patients that go into the ER with vertigo often do not get contrast because they want to peek on their brain if they're having a hemorrhage. So you get an MRI of brain without contrast, which is really not very sensitive to schwannoma. You really want the contrast. And the other feature of your MRIs that you want to look for is that they were IAC focused. That's internal auditory canal focused. That means you're going to get a lot of slices near the eighth nerve. When we get a brain MRI, we hope that there's one slice of the eighth nerve, but with an internal auditory canal focus, you get a lot more concentrated images in the area you are concerned about with schwannoma. So whenever we're concerned about schwannoma, we want MRI of the brain with internal auditory canal focus with contrast.
Got it.
And that's what we have here.
Okay.
Again, just no images though.
Right. No, fair enough. But just, this is something that I think I could say, at least in the years that I've been practicing, you don't, I don't want to doubt, an image or a report. It can be difficult sometimes to reconcile what I'm seeing on my findings. I'm seeing a bunch of central vestibular findings. I'm concerned this person has some sort of cerebellar degeneration. They'll do a standard MRI. They'll say, oh, normal, no lesions, whatnot. And you're just kind of still feeling to yourself like, but this seems like a cerebellar degeneration, for example. So, you understand how this could be challenging.
Absolutely. Sometimes when you get really adept at doing a good vestibular exam on a patient, in some cases your exam is more sensitive than the MRI. So I would encourage everybody not to view the MRIs as the holy grail of truthness. Some things just don't show up on MRI. I've had numerous instances where I've seen patients that have had central involvement and their initial MRI didn't show anything, but subsequent MRIs did. And it's just your assessment was more sensitive to what was evolving. And unfortunately, the MRI couldn't capture it at first. So as we've gotten more and more tools to use, like great infrared goggles, we get more and more insight into the patient's nervous system and vestibular system. And sometimes you're capturing the impairment before the imaging can.
100%. No, it's a good point. And not to go too far down the lane and think that, every time a person looks left that's nystagmus. So we have to kind of walk the line when we're assessing and try to, look for patterns and try to use our best judgment based on, the excellent training that I'm sure that many clinicians have had the chance to receive from courses such as yours. So it's good to kind of think broadly, though. All right. So speaking of more imaging.
So we had a CT done, a follow-up CT. And again, we didn't order any of this. This was done before he came to see us, which was a CAT scan of the temporal bone. And it again, Gemma, now we trust this more for ruling in or ruling out superior canal dehiscence. And so it was read as normal. Now, this is tricky, and this is an important teaching point. If a CT of the temporal bone shows bone between the membranous superior canal and the brain, so there's a bony covering there that's present, the patient doesn't have the disorder. It rules it out. This is a little tangential to our talk a little bit, but it's important to know. Close to 10% of CTs, if you pull people off the street that are not dizzy, demonstrate what looks like canal dehiscence. So we're getting a lot of referrals for patients that get imaging for dizziness, and they have no symptoms whatsoever that suggest that they have superior canal dehiscence, but the imaging suggests that they could have it. So CT underreads bone. So if the bone is there, it's there. But if the canal looks dehiscent, it means they might have superior canal dehiscence. You need the right history, you need the right special tests to make the diagnosis. So if the CT shows it, it means the patient may have it. If the CT is normal, they don't have it. You can rule it out with a normal CT. And so we can rule this out because clearly on the imaging, it's not present.
Right. And if someone comes to me and they're dizzy and I test them and they have clear signs of posterior canal BPPV that, has some nystagmus, goes away in 10 seconds, they feel dizzy at the same time, it goes away at the same time, and we treat that, and then they say, I'm not dizzy anymore. Even if they were to show possible dehiscence, I'm not going to tell this patient or counsel this patient to run and, see a surgeon or anything like that. So we have to just kind of take everything into account. Is that kind of where you're at?
That is great advice, because if they end up in the wrong hands, they go down the road of getting a surgery they don't need. Yeah, the history has to fit. And also, before you have a patient consider seeing a specialist, you might want to find out if those symptoms are annoying enough that they would do anything about it, because the only management of this disorder, superior canal dehiscence, is surgery inside your skull that involves brain lifting. So if they're like, there's no way that echoing in my ear is bad enough that I would ever want surgery for it, well, if you don't want the treatment, you want the workup. Now, some people want to know exactly what's going on. If they want a diagnosis, go through the workup. But if they're absolutely sure they have no interest in the intervention to fix it, it's another reason to maybe
benefits versus risks. We always got to have that thought in our mind, for sure. All right, so then the patient saw a neuro-ophthalmologist. If you want to just kind of briefly speak to that.
Yeah, he saw a neuro-ophthalmologist in our system that we work a lot with, and he could not find a central cause for the patient's complaints. So basically, a central workup was non-yielding. Um, he still thought it could be superior canal dehiscence, even though the imaging did show it, but we talked about that not being a possibility. But anyhow, he referred the patient to us at that point for further investigation with his suspicion that it was not from central nervous system disease.
Got it. All right, so here we have a report. You want to talk through this?
Yeah, so this is an audiogram. It is the test we do with the highest frequency at our balance center. And not almost any balance center, it's a very common test we do on almost every patient, unless you have very straightforward BPPV. That there could be argued it's not necessary. But otherwise, it's very commonly helpful to screen a patient's auditory function with at a minimum an audiogram. So on the viewer's left is the right ear plotted. If it's color coded, right ear is red with round symbols. So remember your R's. And on the left, on your right is the left ear plotted. So the line, it's hard to see the numbers on here, but you see a solid line going across horizontally. That's considered a normative line. And you can see this patient's hearing is really not normal at almost every frequency. So he would have what's described as a mild to at least moderate sensory neural hearing loss. When you hear that, by the way, the first term is where your hearing performance is in the low frequencies. And the second term is where it's at by the time you get to the high frequencies. Because I've seen notes where it says hearing is normal to profound loss on the right side. And you're like, that's really helpful. I mean, it's a wide range. What that means is that the hearing in the very low frequencies is still in the normative range. But by the time you get out to high frequency tones, they can't hear it at all. They have a profound loss. So that's just telling you they have a really steeply sloping high frequency hearing loss. But the hearing loss you're seeing here plotted is very common for, I think he was 70.
Yeah, 76.
76. Just where it gradually gets worse in the higher frequencies. It's not easy to make out, but his word recognition scores are at the bottom of that report, and they were not asymmetric. So does he have hearing loss? Yes. Is it in a disease-related pattern? Doesn't appear to be.
Right.
With superior canal dehiscence, interestingly, you get, let's take a step back. With audiograms, when hearing is assessed, they send sound in through air, through an earphone, that has to go through your external auditory canal, rattle your middle ear bones, and stimulate your cochlea. They also do what are called bone scores, which directly stimulate your cochlea. And with superior canal dehiscence, interestingly, your air scores are diminished because when the sound waves enter your ear, the energy splits. Energy goes in the oval window, out the round window for a normal subject, but in patients with superior canal dehiscence, it goes in through the oval window and splits in two directions. Some of it goes through the dehiscence, some of it reaches the cochlea, so you have energy dissipation, hence reduced sensitivity to sounds in your environment. But remember, we said earlier, your ear is like an amplifier to any sort of internally generated noises, and vibration generates internal noises. So your bone scores can often be superhuman, like you're hearing exceptionally well when your skull's vibrated, but you don't hear sounds in your environment well. So we look for that split in superior canal dehiscence. And that's not present with this patient. So that's further affirming it's really not likely to be superior.
Not looking like it. You got it. All right. All right. So we had some calorics here. You want to just kind of summarize this in a nutshell?
Sure. So with calorics, it usually should be done with water because you run into the least amount of technical error with doing it. In this subject, he had a caloric weakness. I don't remember the exact amount, but it was substantially weak on his Can't make out the
I might
numbers there.
say
Oh, hey,
here.
that's much
Yeah,
more
that might
useful.
be
That's the
better.
right side. Yeah. So he has a right caloric weakness. And so what we're measuring when we do a caloric is when you send warm or cold air or water into an external auditory canal, you indirectly heat or cool the fluid in the horizontal semicircular canal. And when you heat that fluid column, it causes excitation of the canal. When you cool it, it causes inhibition of the canal. And this is a common misconception. With caloric testing, we don't measure the velocity of the quick phase of their nystagmus. We're measuring the velocity of the slow phase of their nystagmus. The fast phase is elicited by your healthy brain.
Right.
The speed of the slow phase is reflective of vestibular function. So when this patient's tested, our subject that we're talking about in our case study, he has substantial weakness on his right side. Now, the value we typically use for caloric weakness is somewhere between 20 and 25%. And I can tell by looking at that it's weak. I have the number here, 1 second. He was 51% weaker on his right side. So that's well above the legal limit of abnormality. So that gives us confidence that there's reduced function on the right side.
And this is testing the horizontal canal. Is that correct?
Absolutely. And the superior vestibular nerve. So it's telling you you're not getting a great signal from that canal and then along that nerve back to the stem of the brain. Something's inhibiting the response.
Right.
So it's a measure of vestibular hypofunction.
There we go. All right, 51% weaker, just as you said. Perfect. So outside VNG completed, 20% asymmetry reported.
So teaching point there is vestibular tests are often not done with high quality. Now, our caloric was not done too long after that caloric was done, but when we looked at the quality of the tracings on it, we were a bit suspicious. So that's why we repeated it ourselves. It's frustrating because what's worse than no information is getting the wrong information.
Definitely.
So sometimes we have to repeat testing on patients even if we don't.
Right. That's tough. All right, VEMPs not attainable.
It's a little unusual because we usually can attain them, but in some geriatric subjects especially, or if there's a lot of adipose tissue in the neck, or if they have trouble holding their head up, we sometimes have trouble attaining responses.
Got it.
We just could not get responses from them on either side, which in some instances can support the diagnosis of bilateral vestibular loss, but his history didn't fit with bilateral vestibular loss. So this just really wasn't helpful. That testing is really helpful to identify superior canal dehiscence because it's 95% of the time or more. At least at our center, we find it very, very useful that in patients with superior canal dehiscence, they almost always have abnormal VEMP testing, which this patient did not.
Got it. All right. So they did look at, some ear situation, anything that you feel like is really revealing here or kind of normal?
Yeah, and this reinforces what we saw at the audiogram, that his Weber test was normal, which implies that his hearing is grossly symmetric. And he didn't appear to have a conductive hearing loss. By the way, patients with superior canal dehiscence, a real simple test you could do is a Rene test where you present a tuning fork to their external ear, and then you put it back on their mastoid. Most patients with superior canal dehiscence will hear bone better than air. In a normal ear, you should hear air better than bone. So think about superior canal dehiscence. You don't need, that's not a major tool, it's just a tuning fork. Bone should be more than air. And when you do a Weber test, it will often lateralize to the involved ear with superior canal dehiscence. You can put a tuning fork on the patient's great toe and it'll vibrate often in their involved ear. We often put on the patella. We call it a patella Weber. And the vibration emanates to the involved ear very frequently with superior canal dehiscence. That's another little bedside test you could do as a therapist to screen for this disorder.
Right, and the great thing about screening is it's just, I always say to the patient, look, I'm not sure about, it could be this. I think you should see this, usually it's an ENT I'm pointing to that could do, more full workup, and I try to touch base with that ENT so they know that's what my concern is, and if I'm wrong, fine. You know what I mean? Like, I'm just.
If you don't have a tuning fork, by the way, have your patient hum, or if you do telemedicine consults, humming can take the place of a tuning fork. So if a patient with hearing loss on their right side hums, and they feel like the humming emanates to the side they have hearing loss on, they probably have a conductive loss. If the humming emanates to the contralateral ear, they probably have a sensory neural hearing loss. So if you don't have a tuning fork or you're over the phone with the patient, have them hum to themselves and see if it's going to their involved ear or to their healthy ear. And it can tell you, give you some insight on what type of hearing loss they probably have.
Awesome tips. All right. Other exam, again, ocular motor looking good. They did have a nystagmus that's horizontal in nature, so to the left when they're in the dark or visual fixation removed. And do you want to go ahead and just review third degree for us?
Sure. So this patient with fixation, so if you had no goggles in your clinic, you ain't going to see anything here because when he can fixate, there's no nystagmus. But if you're using, I would recommend infrared goggles, where you can view what's occurring with gaze holding in this case. When a patient is not fixated, he had left beating nystagmus regardless as to where he would gaze. So it was left beat nystagmus when he was gazing left beat nystagmus when he was gazing centrally, and left beat nystagmus gazing right. If it's present in those three positions, it's third degree nystagmus. It's a succinct way to document. If you're only getting left beating when a patient gazes left, and that's the only place you see it, you can call that first degree left beat nystagmus. So kind of remember, it's like burns. The worst burn you can have is third degree. The strongest nystagmus you can have is third degree left beating. And you want to think this is peripheral for two main reasons. It's only present with fixation denied, and it has the property of being unidirectional, meaning no matter where he gazes, the nystagmus is in a consistent direction. Nystagmus typically will beat to the more neurally active ear, so this would make us think, right hypofunction, and we have a caloric with right hypofunction, so that's unifying. We like that because we're painting a picture of there's more evidence that there's reduced function on the right.
Indeed. Good. And same with the mastoid vibration. We're not going to dig into that today. It's a whole topic I'm actually planning to do in the future because I think it's a great way to get more information. It's not a standalone test, but it's a great way to get more information. But if you take a tool that has 100 hertz vibration and you're placing it behind the ear on the mastoid, and you can do that on both sides, and on the vertex is the way it's written. Vibration-induced nystagmus test, some people call it, or there's skull vibration. There's lots of names for it, actually. But anyway, the point is you're getting this left beat again. So again, that's kind of consistent, I would say, with the gaze holding. So
more evidence of right-sided loss. Yep.
Exactly. You want to talk through this video while it's playing for us?
Sure. This isn't our case, but this is just showing you normal mastoid vibration. So we vibrate the mastoid and the patient gets left beats. On the left, we go to the right, and they get right beat. We see that a lot in normal subjects. So that's an example of normal mastoid vibration, where you're just getting, think of mastoid vibration as a warm water caloric. You're stimulating function transiently, and it's time locked to the stimulus, meaning it's happening right when you do the stimuli.
Go ahead. Tell us about this one, Dr. Walter.
And so in this subject, he has unilateral vestibular loss. And this is, by the way, Danielle, who's involved with vestibular today.
Awesome.
Left beating on the left side. And we go to the right side, and he gets left beating over there too.
Yeah.
That's a highly reliable sign of right-sided vestibular loss, and you can see it takes you about 30 seconds of your time at minimal equipment. I mean, you need the goggles to do the test well, and you need to be able to vibrate a skull at 100 cycles per second. So in our subject, he flunked that test, and that was supportive further of unilateral vestibular loss.
Indeed. Good point. All right. So you just discussed that, master vibration. I love to do a whole journal club on this. I think it has great value. I think it doesn't tell us all the answers, and that's true of almost any test, so I'm good with that. I love more information. That's way more helpful to me than less information, and more objective information, because even though I love my patient reports, they can be very helpful, but sometimes they're not for various reasons. You know, the patients don't always feel things the same, etc., language barrier, you name it. So
one just real quick point on this test that makes
Yeah.
it helpful and that a clinician should realize is if you had vestibular hypofunction in 1978 or you had it last week, you'll flunk it either way. So it's a defect that as long as the hypofunction's there, it doesn't go away over time. So it's always there for you to see. So even though a patient can functionally compensate from a unilateral vestibular loss, meaning that they feel like they're functioning better, this test will often throughout the rest of their life be abnormal. So it gives you that background. It's not something that goes away over time. Spontaneous nystagmus resolves over time from a unilateral loss. Abnormal mastoid vibration doesn't resolve over time. So
and horizontal head shake test can resolve in a good percent of folks as well. So, have
and the head impulse test can look a lot better over time too, as patients learn to compensate because they embed saccades in their head movements. So patients have all these ways of hiding their defect from you, the clinician. But here's the kink in their armor: mastoid vibration.
And knowing that it's old, it just helps me, even if it turns out that they have, I'm not surprised, I'll put it that way, if they end up with BPPV on that side more often. I'm not surprised if, unfortunately, they have some sort of persistent postural perceptual dizziness that I suspect could have gotten kicked off by this. So we're just kind of looking at different concurrent things that could be contributory to an issue. All right, so with that in mind, balance assessment, we can kind of skim through this a little bit, I'd say. The patient sounds like they had some moderate findings, which are pretty consistent with someone with any sort of unilateral vestibular issue, I'll say. Loaded Dixall Pike, which I love and have been using a ton, by the way. Very, very helpful. But in this case, the patient was looking great, no issues with possible BPPV. So we're glad for that. I would say to the patients, yay, it's one less thing to worry about, at least for now. You might get it later. We never know. I'm not making any promises, but today it's negative. And then third window testing that we can do kind of more bedside, we'll say. So this kind of Valsalva, open closed glottis, negative. And you did some Tullio's type assessment, negative, tracheal pressure, negative. Again, ankle Weber negative. So nothing.
Those are all third window tests.
Right.
They should be done with video infrared goggles on, or you're gonna
you would miss it. Right.
So those are all third window tests that were again negative, which is reinforcing the CT being negative. So we can pretty much stick a fork in superior canal dehiscence for this patient because it's just not there.
Right. Exactly. Just because the symptoms sounded a little like it, which is fair to suspect at the beginning, but at this point, we're not there. All right. So we're going to play this video.
So this is our actual patient with this case, and he's going to cough for you because we want to see what's happening when he coughs. This was before COVID, by the way, right before COVID, because this test is a COVID spreader.
Patrick, I'm going to tell you I'm having trouble. What am I clicking wrong?
The play button.
I know. I'm clicking the play button. There we go. All right, video is playing. It was playing. Let's try it again. There we go.
You have audio.
Yes.
So we're waiting for the patient to cough.
So remember, he has a little bit of left beating spontaneously, which is what we're seeing on the screen.
Correct.
It's just a little bit of left beating.
Got it.
Then we're going to ask him to cough, so I don't know if we'll be able to hear that or not. I don't know that there's audio, but
Patrick will make sure it's in there.
You can turn it
Oh, I need to turn it up? Sorry.
See, it's... Yeah, turn it up.
Oh.
I'll fix it.
so he's coughing. So watch what happens after he's done coughing.
Okay.
So let's watch the screen closely after this forceful cough. This is the second time I had him do it that day. It was a little harder to trigger the second time, but just keep watching. So the cough is passed, but watch. He gets vigorous nystagmus. That's predominantly beating to his right. at the beginning, there's a little downward component, but it's mostly right. And you can imagine if he was on his feet with this, he would struggle to function.
Definitely.
Now, a teaching point here is it didn't occur while he coughed. It occurred after he was done coughing. With superior canal dehiscence, the nystagmus we see with that is never as robust as what you just saw, and it occurs while you cough, not after you cough. And so we call that time-locked. The nystagmus evoked with superior canal dehiscence with any special test, like if we send loud sound tones into a patient's ear, their nystagmus is time-locked to sound, it's time-locked to pressure. It's not a delayed phenomenon. So the nystagmus was beating to what we thought was the paretic ear. So it was interesting. That was what we would call a irritative nystagmus. Nystagmus was beating to what we thought was the ear that was diminished in function.
Right. So this is where the vast majority, I would say, of the time, when someone has a right beating nystagmus, it's acting very much like a left hypofunction. It's a reasonable thought. But because the nystagmus beats towards the more active side, if there is this kind of more rare, I would say, situation where something is irritating, can you talk to that just for another minute? Because I think it's a tough thing for folks to maybe kind of cling to it in the beginning.
So trust your caloric for localization. Trust your mastoid vibration for localization. Those are tests that don't lie. Like if there's indications of hypofunction with those tests, they're pretty trustworthy for site of lesion. However, we have other tests sometimes where nystagmus can go one way or the other. One is hyperventilation. That's probably the one you should know about. When a subject with hypofunction from, say, a vestibular neuritis hyperventilates, they can commonly get a nystagmus. It's really light that beats to their healthy ear. We would not call that, that would be expected with the paretic ear. You have the patient hyperventilate. They get a little bit of nystagmus beating to their healthy side. It happens because you increase nerve conduction velocity by hyperventilating on their good side, but their defective side can't generate that increased input, and so you get some transient asymmetry and nerve conduction velocity from each cranial nerve. When just your myelin's irritated, so the surface of the nerves being irritated by something, multiple sclerosis, vestibular schwannomas. When you hyperventilate, interestingly, that can cause transient hyperexcitability from the diseased side, and now you have nystagmus beating to the diseased ear. And it tends to be, in these cases, more violent. So that was one thing you would think about in this case. However, in his case, I had him hyperventilate twice. Now, he coughed and showed you nystagmus, but twice I had him hyperventilate vigorously and got nothing. I did not get irritative nystagmus with him hyperventilating. So it did not seem to be a hyperventilation phenomena in this patient. Back to, is there a third window we're missing? I don't think so, because again, it wasn't time locked to the pressure. It was occurring after. Now, was something compressing his eighth nerve is another thought, because during cough, you increase intracranial pressure. So if there's some sort of space-occupying lesion in the internal auditory canal on top of the increased pressure from coughing, is that what's irritating his nerve? So we wanted to see not the MRI report, but the actual MRI film. Because I'm just being honest with you, just learn not to fully trust anyone or anything. Like sometimes you gotta look at things yourself.
Fair.
So we asked him to cough up his actual images and bring them in.
Good. All right, so with that in mind, we're gonna play one more video.
This is an example of a patient with a vestibular schwannoma, unknown at the time, by the way. He didn't know that he had it, but when he hyperventilates, he turned out to have a left-sided vestibular schwannoma. We had the patient hyperventilate and watch what happens on the screen. This was a patient presenting, by the way, with exertional dizziness. I exert, get my heart rate up, I feel like I'm spinning, which is a red flag, by the way, as a therapist. If you're seeing a patient who has exertional vertigo, that should be delved into further. And you can see this patient gets robust left beating when he hyperventilates. That's an irritated nystagmus because his tumor ended up being on the left side. Well, interestingly, his first MRI was negative. His second MRI showed the tumor. So we talked about this earlier. He's lateral pulsing to his right also. You fall away from your fast phases. So when you have left beat, you fall right. And when you have right beat, you fall left. If he was standing, it'd be more impressive because we maybe have to fall.
Right. Right. Not to be confused with patients who present post-concussion with some sort of dizziness with exertion that could be dysautonomia or, so again, that's why the description alone, it's a piece of information, but we want to do our testing and any kind of, whether it's bedside tests or something that could be ordered to try to sort out, what we're dealing with here, right?
Yeah, if your patient has strong, robust nystagmus evoked by hyperventilation, they need to see an otologist or a neurotologist or go to a balance center, and they need an MRI. Because the most common reason to see that is a vestibular schwannoma. Now, if they have exertional dizziness in the complete absence of nystagmus, then you could be talking more about concussion, like you just mentioned. I'd be a little less concerned about a more sinister cause in that case. So that's a differentiating point. Is there nystagmus present with it or not? And again, the infrared goggles are very helpful for that.
Awesome. All right. So keeping that in mind, this patient, in summary, had this kind of coughing that potentially increased this intracranial pressure. And then there's kind of some theories that you kind of have covered here about kind of increasing the compressive forces in the internal auditory canal during coughing, which creates a transient neural irritation on that right side, which otherwise was acting like a hypofunction side, as we pointed out. But then we did get that right beat with that cough. Does that sound like an accurate summary there?
Absolutely. We think site of lesion is on the right, but what's creating it still sort of a mystery, but I think we're getting to it here next. We want to see the actual MRI film because now we're thinking, is there a space occupying lesion in there? So interestingly, here's his MRI. That was reported as normal. I held the MRI report and said normal. But when he brought a disc in and we loaded it up and looked at the film, if you're not familiar, on your left, the viewer's left, is what's called an axial cut. And I kind of wish I had a pointer, but
here, I can help.
The nose is towards the ceiling, back of the head's towards the ground. And you can see an enhancement along the patient's eighth nerve on his right. So when you're looking at an axial MRI cut, the patient's lying in bed and you're at the foot end of the bed looking up into their head. So you're at the foot end of the bed looking into their head. So it's like your view's inferior. And you can see the highlighted mass on his right nerve, on his right, and the eighth nerve on the opposite side coming out of the brain stem is clean. So you can really see the stark difference between the two sides. And so on your right is what's called a coronal. So now you're looking at the patient. And again, you can see the mass, which is, again, with using dye, it gets enhanced so it's easy to see on his right. The left side looks clean.
The bright
so
white.
He has a right-sided vestibular schwannoma that was not recognized
initially.
We called the radiologist who had interpreted his MRI report, and he amended his report.
I would imagine so.
Missed it. And in his defense, the imaging was ordered for what purpose? To look for
superior semicircumferential. Okay, really exactly.
And kind of missed something else, and it happens to all of us. I mean,
we've all made mistakes. Right, exactly.
And frankly, it really didn't change the course of things, except he got probably more testing than he needed. But there's our culprit, we believe.
Yep. So you're going to kind of monitor over time, which we talked about in the beginning. And then 2 months after the initial visit to your center, the severity of symptoms did increase. And then there's a mention of a dizziness-associated motor vehicle accident. So the patient was feeling dizzy. I believe they were driving, and that was not
driving,
good.
and he coughed.
It is not good.
He had to cough while he was driving, and he went
Right.
into an attack. He didn't have any severe injuries from it, but he had a car accident from the cough-induced vertigo.
This is where function is being impaired. This is a safety issue. This is, something that is getting to where it should be addressed for safety is what I'm hearing. Does that sound like about where we're at? So he tried the stereotactic radiation therapy, and then it's described that he had a complete hearing loss in the right ear, and then the cough-induced dizziness went away.
Presumably because he lost his function. As that tumor grows, or if it's further damaged by radiation, it's not just damaging the tumor, you damage some of the nerve around it. Once his ear became dead, it stopped. And he was happy. He was happier being deaf in that ear and having the stable vestibular, which you could
homeostasis.
Compensate for. He was a happier camper than he was when he had hearing, but had this irritable, changeable ear that was altering its behavior depending on how much he exerted.
Right. So take-homes include vestibular testing may need to be repeated due to variable quality. Another take-home is that because you have a radiology report is not necessarily the final word, and consider that when you're a clinician kind of getting these reports. We're neither ordering it as a PT nor are we reading it. So you consider yourself not at the mercy of those, but rather just to be willing to maybe be a bit of an advocate. And the experience definitely helps this, I would say. I think you could speak to that as well, Dr. Walter. Kind of the more you see in your clinical exam and you're saying, this is not adding up for me, right?
Yeah, I've been really fortunate to work with the physicians at our center closely, and I'm really comfortable just through experience and repetition at looking at temporal bone CTs and MRIs to look for eighth nerve issues. I think if you become an experienced therapist, I think getting comfortable, at least screening through imaging, can be helpful in expediting a patient's course of care. We're not radiologists, but it's nice to be able to at least view those and have an idea of what you're looking at. And if you're concerned about something, seeing if it's on the imaging or not.
Yeah. And this can really be challenging depending on your team around you, if you will, and geography and what doctors are in your area. But, whenever possible, definitely building good relationships and good communication with as many different neurologists and ENTs and audiologists as possible, and to maybe advocate occasionally for some sort of consideration of second opinions and things like that, just to try to kind of, cover the bases on a person who's just not matching up, or that you really kind of feel like you have more concern about. Would you say that's true if you're not so blessed as you are, Dr. Walter?
Yeah, I loved vestibular rehab as soon as I got into it, but I loved it even more when I worked in a setting where you can go down the hall and there's an otology PA or there's a neurotologist that you can dialogue with on difficult cases. They can go across the hall, get an audiogram, they get vestibular tests. It's just, you get so many more answers when you're in a multidisciplinary type setting. But if you're not in that setting, you have to advocate for your patient when it's appropriate to pursue those services. It just makes it a lot less efficient.
Right.
I'm the kind of person that likes quick answers. I don't like long-term mysteries. So
right.
My personality is better suited by the clinic setting that I'm working in now.
Yeah. Well, there's the good news is for those who don't have as many resources, telehealth is a thing. I've definitely had a patient who had their images in hand, because it's their images, and had someone very, very experienced take a second look at them, for example. So that would be a possibility. Or some patients will travel, to perhaps a larger medical center with someone who's more specialized. Not to say that someone who is a general ENT can't catch these things, but again, it's not always easy. It's not always clear. These patients, they're not always cookie cutter or textbook, as this case clearly highlights. So
I would say if you're getting into a case like this, I would encourage your viewers, don't just send the patient to a general ENT. They really need to see an ENT that specializes in otology. I would say out of the patients we see, for example, with superior canal dehiscence at our center, most of them had already seen a local ENT that kind of just threw up their arms and couldn't figure it out. But you're not going to get superior canal dehiscence past an experienced otologist or neurotologist. So those are subspecialties within ENT where they're just very focused on ear-related issues. I think if you're running into difficult cases like this, if the patient has to travel a little further, if you could get answers in a visit or two versus, seeing a generalist and maybe not getting those answers, it might be just worth the time to do the extra travel.
Indeed. Agreed. All right, so with that in mind, we're going to wrap up with some resources and some questions, and I think we're definitely be at over our hour, as I usually am, unfortunately. Sorry, guys. There's always so much to talk about. So, Dr. Walter, you already mentioned you're seeing patients, you're teaching courses. I've put some links there for places where you can find Dr. Walter's courses, of which I'm aware. And then you have a beautiful page of resources on Vestibular Today's website, so folks, please check that out. A wonderful Atypical BPV Part 1 and 2 podcast on Talk Dizzy to Me that I highly recommend watching. And then if you're not sure what the loaded Dix-Hall pike is, which I briefly mentioned, Dr. Walter was key in developing that, and it's an excellent added tool for your toolbox. So there's information on that if you want to watch a video on that or want to learn more about that. So lots of resources that we can thank Dr. Walter for. So with that in mind, our first question that came through email was, what are the main differentiating factors between BPPV and other types of vestibular issues? If you could touch on that for our physician here that wrote in.
Wow. Well,
I know, you only got 1 minute. What do you got?
With BPPV, the episodes of dizziness should be pretty strictly just positional and short. There should be an absence of cochlear-related symptoms like we talked about earlier. There should be an absence of spontaneous attacks of dizziness. Whereas with other vestibular disorders like Meniere's disease or when an acute vestibular neuritis evolves, there's a spontaneous nature to the patient's vestibular symptoms. With vestibular schwannoma and Meniere's disease, there's cochlear-related complaints often in the evolution of their symptoms. So those are some differentiating points that I would look at.
Definitely. And I know that it's dangerous to go just by symptoms, but I have read at a few places that if a patient specifically describes some sort of symptom when turning in bed, that can lend itself to make you much more suspicious of BPPV. Of course, you want to do your Dix-Hall pike, loaded Dix-Hall pike. If you need to do side lying tests, do your positional tests, and looking for the nystagmus and vertigo that usually comes and goes together. That's my experience. Would you agree with that as well?
Yeah, we don't trust. Just yesterday, I had a patient in the clinic that had classic BPPV, but they swore when they experienced their symptoms, they could not get away from the term, I feel like I'm going to faint. I feel like I'm going to pass out. And I was with a neurology resident that was observing with me. We were done taking the history. All the triggers for BPPV were there. The duration was all seconds. There was no other concerning cardiovascular issues. It just was classic, except the patient's description of the quality of their symptoms. And we've learned not to trust that.
Yes.
So trust timing and the triggers.
Not the symptom description.
And how a patient experiences vestibular dizziness, because it really varies from case to case.
And throw it out the window, honestly, if they've had a central vestibular issue in my general experience. So brain injury, concussion, cerebellar stroke. I had a lady, she just had constant nausea. We knew she had an old cerebellar stroke. That was known. But now she had this new constant nausea. Sure as shooting, she had left posterior canal BPPV. When I put her Dix-Hall pike, classic left torsional upbeat. And then it went back to her classic downbeat after that resolved. But you know what I mean? So just kind of, watch for that as well. All right, some good tips there. And our second question, and then we're going to wrap it up here, is what are the most effective ways to communicate with other healthcare team specialists and referring providers about findings, concerns, and recommendations for additional testing.
Well, I tend to be pretty direct because I'm very comfortable with the people. I'm just thinking back to my earlier days. I mean, it's good if you can establish credibility through good patient outcomes with service, because then they'll listen to you more once they begin to trust you. I often in my notes, when you get into, as a therapist, suggesting alternative causes of a patient's dizziness, I often term it as suggestions or put a question of it. So that helps. Yeah, I mean, communicating your findings in a way that the physician can understand it when you talk to them, I think is important. Your way into it, by talking about the history and the findings that you have are concerning, instead of just a patient needs an MRI.
Right.
Background as to why you're concerned about it. And even kind of let them see if they come to the same conclusion you want them to reach without you offering it. I think there's an art to that, but if you can kind of craft the history and your concern with your exam and then sort of just leave the idea of, well, what's the next management option? If they come to the same conclusion you were going to anyhow without you having to suggest it, that's probably good. The more you develop that relationship, I think the more direct you can be. I guess the things I would say.
The other thing I would add, if you agree, I don't know, but occasionally, for the primary care doctor particularly, because they tend not to be as trained in vestibular care, which is understandable because they have so much else they have to be responsible for, as I'll say. This presents very similarly to some other patients I've had with the same issue, or I saw on the video they had this particular movement of eyes that's very consistent with other things. When I kind of speak to my experience a little more indirectly, say I'm just concerned for this. I was thinking maybe this would be the next step. What do you think? Still open-ended question at the end. I hope that they would kind of, get on board.
Yeah, and I would always interpret vestibular findings in the context of the patient's history, because I can't tell you how many patients that are 80 and above I see that have a little bit of downbeat nystagmus here and there, but have a history that's very benign, and they might just have BPPV or something. Always be a little careful about overweighting abnormal vestibular test findings that in the context of the patient's history do not seem concerning. So don't overinterpret some of the things that you see. Always, you want to be most concerned when the history's concerning, and then you got exam findings that are concerning hand in hand.
Right. Well, this patient is having a ton of falls, and I'm just seeing them when they lose their balance, they don't have any reactive response, or, things where I'm kind of like, okay, something serious, here, and, they had intention tremor, just things that kind of are more in that genre. So with that, we're going to wrap it up. Thank you, everyone, for hanging in with us if you did this long and to learn about this really unusual case of vertigo. I hope you picked up a few pearls, tips, and ideas to enhance your vestibular care. And we give a special thank you to you, Dr. Walter, for being with us today.
Thanks to all your efforts that you've done to develop a tool to help therapists do their job, because not having video goggles, this has been said before, I think by Michael Hamagi, is like a carpenter without a hammer. So if you want to know, if this is what we look for when we send patients out for vestibular rehab at satellite sites that even aren't associated with our health system, is do they have video goggles? Because if they don't, I know that they can't do an adequate vestibular assessment on patients. So that's a really important tool to acquire. And you've done so much work to bring an affordable set of goggles to so many therapists. So thanks to you for all that work and all the educational work you're doing too.
Thank you. Well, I think we both have the common passion, so we keep working to get things to the next level. So thank you, everyone, for joining us again, and we'll hopefully see you all next month. We'll have another excellent topic on our Journal Club.
Thanks.